Hi viewers, and a warm welcome to another episode of Today's Parent, where we not only connect you with experts but provide you with information to make your parenting journey a bit more easier. I'm your host, Christine Kasina. In today's episode, talking about connecting you with an expert, we are connecting you again with Dr. Kireki. He's one of the best fertility specialists here in the country. And today we are talking about premature ovarian failure. It's something that a lot of you have sent questions about, and today we want to address that. Dr. Kireki, welcome to another episode, and it's a pleasure to have you again. Dr. Kireki, I'll be honest with you, when it comes to premature ovarian failure, it's something I was not aware about and I've not heard in my circles. It's not something I've heard a lot of the women talk about it.
Actually, you may not hear a lot about it because it happens quite rarely comparative to other issues which ladies come to us with. When you talk about premature ovarian failure or premature ovarian insufficiency, it basically means that there is a patient. Most of the time they are young patients, and they come to you because they've been trying to have a baby and it hasn't worked.
Right.
We have eliminated all the other reasons. When you do their hormone, their blood test to look at their hormone levels are all over the place.
Okay.
I can give one example which I had this last week, where there was a young lady, young 26 or 27 years old, which is a young lady basically. She had got married and they've stayed 1 year. And they have been trying to have a baby. I mean, the expectation is that a year after marriage, you should be having, at least you should be pregnant. When I went through the history, one of the questions that we normally ask is, how often do you have intercourse? And it's quite normal. That is a young married couple. They have intercourse regularly, actually daily. They don't use any contraception, and a year has passed, and there is no showing. There is no pregnancy. The gentleman has another wife, an elder wife, who has 4 children.
Right.
So there could be something. So the first thing is there could be something with this young lady. She came from, I think, from the northern part of Kenya, somewhere.
Okay.
So she came and saw my colleague, and the first thing, of course, my colleague did, she did all these tests, and then one of the tests that she did is called FSH, follicle stimulating hormone.
Okay.
Now, follicle stimulating hormone, what actually it does is a hormone which tells the ovaries to actually produce an egg or eggs for that matter.
Right.
Now, in young ladies, this follicle stimulating hormone in the reproductive age or in the reproductive period should be actually less than 10, equal to or less than 10. But in this lady, it was, I think, 56.
That's high?
Very high.
Very high.
We expect it to be that high in patients who are menopausal or postmenopausal.
Okay.
So here is a scenario. You have a young lady of 26 years old with an FSH of 56. So the first thing that comes to mind is actually premature ovarian failure. There are several reasons why a lady can have premature ovarian failure. So the first question we ask, have you had any surgery, ovarian surgeries? Because if you have a cyst or there are cysts on the ovaries and surgery is done, and if the surgeon is not very careful, he or she can actually remove quite a bit of the ovarian tissue, which actually has normal ovarian, which has follicles, and this will actually lead to premature ovarian insufficiency or premature ovarian failure. So that is number one. Number two, age is a factor.
Okay.
The older we become, the lower the number of eggs which remain, which is a natural process in life. So I wouldn't expect a lady who is, let's say, it would be normal if I find a lady who is 50 or 40 something
who has POF,
who has follicle stimulating hormone is elevated, is perfectly normal.
Okay. But
not in a lady who is 20 something, early 30s.
Okay.
The other issue is one of the other reasons could be because of chemotherapy. There was a patient I had who actually had cancer of the kidney when she was very young.
Okay.
So they removed the kidney, and obviously, unfortunately, they gave her a chemotherapy, which was life-saving. So she was now 28 or 29, but she did not have, her FSH was 100 and something.
That is very high.
That is very high. Radiotherapy again, when it comes to treatment of cancer, if we give these patients radiotherapy, we treat them with radiotherapy, it definitely is going to lead to premature ovarian failure.
Okay.
Now, there are other issues as well, which are not very common, but could be a reason for that. You may find that the immune system itself can actually be against the ovaries. So the immune system treats the ovaries as something which is foreign and which needs to be quarantined and acted upon and stopped. So by doing this, you find that these ladies have premature ovarian failure as well. Obviously, we mentioned surgery. These are some of the big reasons. If you find some researchers would even suggest some viral infections. Mm-hmm. That can also be a reason. But we don't see very much of that, but it is a potential reason as well.
Okay.
Yes. Now, when it comes to how do we know that this lady or these ladies have premature ovarian failure, number one, they are trying to have a pregnancy and it's not happening.
So these are the symptoms we are talking about.
These are one of the symptoms, yeah. Mm-hmm. You come to us, they come to us because they're trying to have a baby and it's not happening. When we do a scan, we actually find that the ovaries are a lot tinier than how they are supposed to be. When we look at the ovaries on a scan, we find that actually what we call antrofollicles, mm-hmm. you actually cannot even see them. So this is a signal that something is not right. So infertility, you're trying to have a baby, ovaries are very tiny. When you send them now for a blood test, you find that actually the FSH is very high, mm-hmm. Vis-a-vis the age. Okay. We do what is called AMH, an anti-Mullerian hormone, which actually gives us an idea about what we call the ovarian reserve. We find that the AMH is also very low. So very low AMH, very high FSH, tiny ovaries, no antrofollicles, infertility. It's a classic example of premature ovarian failure.
Right. I'm just wondering, because POF is where your ovaries don't produce eggs at all.
No, the eggs could be there, but the quantity is very, very, very
low.
So
the issue is the quantity.
It's the quantity. Because normally ladies are born with a set number of eggs. Okay. And this number of eggs decreases with time. Okay. Every time when a lady has a period, it means that several hundred eggs were produced. One egg became what we call the leading dominant follicle. An egg was released. Mm-hmm. So in the process of getting to that dominant follicle, all these other eggs, about 500-700 eggs were actually, lost, as it were.
Okay.
Yes.
Would you advise, Dr. Would you advise if somebody has irregular periods, even before you get to the point of thinking about marriage and that stage?
Yes.
Would you advise that they check in with a gynecologist or a fertility specialist to know the health, the health status of their system?
I think it makes sense. I think it makes a lot of sense. I think one of the questions which you had asked before, there was a lady who hasn't had a period for 7 years.
Yes.
So the question was, before this time, was she having regular periods? Let us assume that she was having regular periods. Then if she was having regular periods, and then for the last 7 years she hasn't had a period, there is something that is not right. Okay. And so the first thing that we think about, after eliminating all the other possibilities, then doing the other test is we have to think about premature ovarian failure. Okay. Yes. Okay. So it is a good idea before you get married. I mean, just come and have a test done.
A checkup.
Just have a test done. A simple blood test. Do a scan. I think it's a small investment vis-a-vis,
waiting that long, and then having to deal with it then could be a bit late.
Yes. Okay. In terms of psychologically as well, because most of these ladies, when they come and we tell them, you know what? Yes, there is a problem. And this is the problem. But they say, in my family, all my sisters have children. They are very, very productive. They are very, very fertile. Then why me? Mm-hmm. And then, we have to find a reason to say, well, the problem is not you. The problem is your system, basically. Yeah. And that is beyond you and is beyond anybody else.
Okay. Dr. What are the effects of polycystic ovaries? Ovarian failure. Yeah.
The effects of premature ovarian failure. I think number one is you will not be able to have a baby, your own genetic baby. In that, if you have premature ovarian failure, the quantity of the eggs is very low.
Like you mentioned, yes.
So even if we try to stimulate you, we may not get any eggs. Or if we do get an egg, we may get one egg, maybe two eggs, poor quality. If the eggs are poor quality, most probably the embryos will be poor quality.
Okay.
The chances of them, implanting are also very low. So I advise the patient, say, look, it's a very expensive procedure to go through. And if you're going to go through this procedure and you invest so much money, in order to get one egg or two eggs which are of poor quality, it does not make a lot of sense. However, there are patients who say, you know what, let me try. At least I will know that I have done everything, within my ability to get my own child. Once we've crossed that line, then I can think about other possibilities.
Okay.
So the effect is that, number one, the periods can be regular or they may not be there. Okay. And once we have excluded all the other reasons for irregularity of periods or lack of periods for that matter, then we make a diagnosis. Once we made this diagnosis, at least, as most people say, a problem is half solved when at least you know what the reason is.
Yeah.
We know the problem, so we can solve it.
Okay.
That way,
So apart from lack of menses or infrequent periods,
yes.
Dr. Google tells me the other symptoms as well. We may confuse them with menopause, like you had mentioned earlier.
Yes.
Hot flashes, night sweats.
Absolutely.
Is this true?
Absolutely, it is true, because if you look at the hormone levels, you find the hormone levels are actually hormone levels which a lady who is of a certain age should be having.
Yeah.
And then here you're having a young lady having the same hormone levels, and these are the effects. Yeah, lack of periods, infertility, you may have hot flashes, you may have memory, some issues with memory loss sometimes, you may have palpitations, mood swings, etc. And then later on, you can actually have issues with the whole body system. Osteoporosis can set in, and so on and so forth. High
Even
blood
when
pressure.
you're young, as young as you are.
Exactly, because basically what we are saying, or what your body is saying, it is not producing the female hormone, the estrogen, which actually makes women be women.
Yeah.
So think like women, behave like women, the body to be a female body. So it is not there. So in the lack of it may be very, very small quantities, which are not enough to actually sustain the body to behave the way it is. So in the case of that, people don't actually know, we actually don't think about it, that actually that estrogen makes you think, so psychologically, makes you think like a lady. Your organs, all your organs, in order for you to have a period, you need that estrogen. In order for you to have an interest in actually having intercourse, you need that,
also
that estrogen.
Then low libido is another side.
Low libido is another
well.
one. In order for your vagina to be actually well hydrated, you need estrogen. So if it is not there, you'll have dryness of the vagina. So nobody wants to have intercourse when the vagina is dry.
Yeah.
It's problematic, it's painful, and so on and so forth.
Okay.
Now, another thing is that the protection in the vagina is basically because of estrogen, because it is acidic. What you call the pH in the vagina is acidic.
Okay.
So the older we become and we lose this estrogen, we lose that protection, there are chances of infections which are a lot higher, and so on. So it is a whole plethora of actually symptoms and signs and things which are going to happen because that estrogen is not there. And estrogen, most of it is produced by the ovaries. A bit of it can be produced in the fatty tissue, but is a small percentage. So there we go. We remove that estrogen, or we have very little of it, we have all these symptoms, unfortunately, at a very young age.
Dr. You've just seen my expression. I'll stop you there so we can take a short break.
No
and then when we come back, we'll talk about the diagnosis part and the treatment as well.
No problem.
All right then. Thank you very much. In today's episode of Today's Parent, we have Dr. Kireki, who's a fertility specialist. We are talking about premature ovarian failure. We've talked about the causes and what it is. When we come back from the break, we are going to talk more about treatment and diagnosis. Don't go anywhere. Welcome back to today's episode of Today's Parent, where we are talking about premature ovarian failure. And in studio, we have Dr. Kireki, who has shared insights of what it is And at this point in time, we are going to talk about diagnosis and treatment. Daktari, we are back from the break.
Yes.
And you know, when we did the first part, it sounds so gloomy, and it's almost like 100% that nothing can be done if you have POF.
POF. That is, I'm glad you said it sounds like. So it means that even if there is such a situation, there are things which can be done that to alleviate or even to help these ladies. So number one, the first thing before we make a definitive diagnosis and then plan on how to help these ladies is to do some tests. I mentioned, I think, in the other part that we need to get some information, medical information,
the history
of the patient.
Yeah.
Even family history is very important as
well.
Is
it genetic, by the way? Could it be genetic?
They say sometimes it runs in families, but I can't tell you 100% that it is genetic, because then it would mean that there is a particular gene which is responsible for this, which it has not been isolated.
Right.
So it may run in families, so quasi-genetic. But in order for me to say that definitively, we must have a certain gene, which we don't know at the moment.
Okay.
So, so the history is important. And then number two, we need to do some tests. We need to do a blood test. And the blood test, basically, we look at hormone levels. And there are several hormones we normally look at.
Okay.
We look at what is called AMH, anti-Müllerian hormone. Anti-Müllerian hormone is basically a hormone which tells us about your ovarian reserve. It doesn't tell us that Christine today has 20,000 eggs.
Right.
But it just tells us, well, if it is high, it's quantitative. If it is high, it means there's a good ovarian reserve. If it is low, it means the ovarian reserve is low. If it is very low, then obviously it's what we call diminished ovarian reserve. Just as a detour a little bit, usually patients who have polycystic ovarian syndrome, we talked about it some time ago, usually they have a very, very good ovarian reserve. Very, very high.
Interesting.
Which is very good for them in a way, okay? But then again, because of that, they may also have issues. You know, our bodies are quite interestingly designed. So we do anti-Müllerian hormone, which in such a case of premature ovarian failure, we expect it to be very low. Sometimes it can be extremely low, almost negligible. 0.01, for instance, nanograms per milliliter. Now, we do follicle-stimulating hormone. As I remember, I mentioned follicle-stimulating hormone is the hormone that produced by a part of the brain called the pituitary gland. Is the one which actually tells the ovaries to actually produce an egg, which is going to be utilized in that cycle.
Right.
We expect normally, under normal circumstances, FSH is supposed to be less than 10. But in such a case of premature ovarian failure, it's usually quite high. It can be 50, like the patient I talked to you about. 56, can be more than that as well. We do also TSH, that is thyroid stimulating hormone. This is basically to make sure that the lack of periods, because these patients usually don't have a period, the lack of period does not have other issues, is not related to the thyroid gland or to something else.
Right. Okay.
We also do what is called prolactin. A high prolactin level, hyperprolactinemia, can also be a reason of these patients lacking or not having a period.
What does prolactin do to the body?
That one is another topic altogether, but just to give a signal. Prolactin is a hormone also produced by the pituitary gland. It's the one which communicates with the breasts and tells the breasts produce milk.
Okay.
A very normal situation when a lady is expectant, because it is naturally produced that way, because the body knows that there is somebody there
on the way,
who is actually going to be a consumer of this milk. God has created us in a fantastic way. For those ones of us who think about evolution, I don't think evolution has anything to do. This is a master design.
It's very interesting, and you're a scientist for that matter.
It's a master design. Christine, it's not possible. I mean...
But this was a mistake, you know, from a big bang.
By chance?
No.
A big bang in a vacuum? It's not possible.
I'm with you on that one.
It is not possible. So prolactin, actually, if we have elevated levels of prolactin, what they actually do, they go and suppress what is called GnRH. So the GnRH is actually what tells the pituitary gland to start producing follicle-stimulating hormone, LH, and so on and so forth. So it actually stops the normal reproductive cycle, and your body thinks that you are pregnant, even though you are not pregnant. So we also need to. So we need to eliminate all these other possible reasons of lack of periods.
So that is how you diagnose.
That is how we diagnose. But before we even finish, we also need to do a scan. What does the scan tell us? Sometimes you have these patients who come and they say, I've never had a period before. So what is the problem? Could the problem be on the ovaries? Could the problem be in the womb? Etc, etc. Sometimes you find these patients don't have a womb at all. So we also need to eliminate that as a possibility. But then an indicator which can actually give you a sign that the womb is there is that they have had periods before, they have been irregular, but then they say from a certain time, Daktari, from last year, from two years ago, my periods started becoming irregular, and then they stopped. So then there is a problem.
Right.
So we need to have a look at that. Now, once we have collated this information together, we look at the AMH is very low, FSH is elevated, the womb is there, the ovaries are tiny, she has been trying to have a baby, it hasn't worked, so there is infertility, which is secondary to premature ovarian failure. So we have a diagnosis.
Okay.
So now how do we proceed from here?
So now we are talking about treatment.
Now we are talking about
possible treatment options.
Exactly.
Right.
Now, the patient will tell us, you know what, I've been trying to have a baby. So we have to address the issue of infertility. And another one will tell us, you know, I don't know what is happening. I am not married. I'm not planning to have a baby at the moment. I just want to have my periods back the way they were. So it's a completely different approach. Now, when you talk about the patient who wants to have a baby, the first thing we have to do is we have to be very candid with her and tell her, with the hormone levels that we have, the chances of you having your own baby, meaning using your own eggs, is almost not there. But this does not stop you from having a baby. You can have a baby by using somebody else's eggs. So we can use egg donation. We get eggs from somebody else who is in a good reproductive period. We get sperms from her partner, and we fertilize the eggs, and then we prepare her womb for acceptance of these embryos.
Wow.
Now, actually, they do get pregnant. And you see, the thing is, once this lady has got pregnant, I mean, she's not going to shout and say, you know, mayai nilitoa mali pengine, sijui nini mtoto. And even if they did that, who would believe them? Si wanaona mimba imeshika. Wanasema tumshukuru Mungu, and we should actually thank God for that. Sindio?
But I have a question. If I, for example, was going through that, then I get the eggs donated, say, from somebody else, like you say, and then the sperm from my partner, psychologically dealing with it as a woman, that this egg is not mine. Do you offer some form of counseling? Yes,
counseling is important because it's very important. It's extremely important because the question that actually arises is but this baby is not mine.
Is my DNA there, by the way?
Your DNA will be very, very small.
Wow.
Very, very small. Because of the exchange, the blood is yours and so on. It will be very, very, very tiny. But if we were to do a DNA test, the baby, obviously, your husband's DNA would be more than yours. But then there's something else which we need to bring out again. There is the biological parent or the biological mother, and then there's the social mother. Now, ideally, it should be both. That the baby you are carrying, you are the genetic or biological mother, and you are the social mother because you are bringing this baby up. Now, in most instances, in these ladies, there will be more of the social mothers because they are bringing this baby up. It is your baby because you've carried this baby. You've gone through all those nausea and vomiting, discomfort of pregnancy and so on and so forth. This baby is actually yours.
My baby.
This baby is yours.
I will take 100% ownership.
300%, more much 100%. Because when you feel this baby kick in you,
you connect.
You connect straight away. So there is a way out. We can help these patients to actually fulfill their dreams of becoming mothers.
So the good news is that it is treatable.
It is treatable. we can use other methods to actually help them to overcome this huge hurdle, which is biological, and there's nothing that they can do about it. Now, if it is another issue of the other issue of this patient doesn't want to have a baby or is not ready to start a family, but she wants to have her periods back,
regular periods,
then number one, because you remember they've not had periods for a year, sometimes 2 years.
7 years.
Or even 7 years in that case. We need to do the scan that we did, we need to look at the lining of the womb. And usually the lining is very thin. By thin, we mean maybe about 2 millimeters, 3 millimeters, 4 millimeters. Now, we need to build it up. So we build it up, the lining, by using some medications. And when it gets to a certain size, we're talking about 7.5 millimeters or more, then we can actually induce a period. All right? Now, once we have induced that period, we can put these patients on oral contraceptive pills or hormonal contraceptive pills. Very important, because they will have a natural period. And this period is not really a natural period, as it were. It's an artificial period. Why? Because it's basically the hormones which are working on the lining. So long as the hormones are there, when you stop or when they finish taking the tablets, that effect of the hormones is not there on the lining, so the lining will actually come out as a period. So the periods will be there cyclically every month, so they have to continue being on these medications. Now, the other thing is we can actually do what is called supplementation of the estrogen, which is lucky. Remember, we talked about estrogen and its effect and what it does to the body. We can actually do what is called hormone replacement therapy. What does this mean? It means that, yes, we know there's a problem. Estrogen is not being produced, and we need to supplement, to give you this hormone artificially. They can either be tablets, which you can swallow every day. They can be, what do you call, plaster.
Like a patch?
Like a patch, which you can use every so often. Sometimes you can use cream, which you just smear on your skin every so often, and so on and so forth. The purpose here is basically to supplement the estrogen that was there.
Thank you, Dr. Ari.
You're welcome.
And with that, we come to the end of today's episode of Today's Parent, where we had Dr. Kireki talking about premature ovarian failure. And the one thing that he has shared, the good news is treatment is possible. So don't despair if you suspect that you have POF. I have been your host, Christine Kasina. I hope you found this show to be very insightful and it was useful to you. If you have any other questions for Dr. Kireki, just send us an SMS and we'll find a way to connect him to you. Thank you for watching. We've been here in studio at Little Cribs, the home of fun, exciting and durable kids furniture. If you're looking for parenting resources, head on to www.supermamas.co.ke. We thank you for your time. See you next time.